ends up just being us, you know, a little bit into the presentation. Maybe we can just kind of tailor it to questions you might have or how I can best help you. But I'll go ahead and get started. So we're going to talk about some medication access programs. And before I get started, I will talk a lot about various cardiovascular medications. I don't have anything to disclose. I did not do a formal disclosure slide, but I have nothing to disclose. I'm just purely trying to provide information around a lot of medication access programs that you may encounter in the cardiac kind of realm of pharmacotherapy. Nothing is a preferred agent. I'm not trying to endorse anything here. Sorry. So as far as my objectives, we don't have a ton of time here today. So there's only a few. We're going to describe kind of the whole process for obtaining medications, and then really try to identify some useful medication access resources. And if you guys have access to this after the presentation, there are some hopefully useful links in here for you to utilize in your own clinics or your own practices. So new therapeutic molecules are being studied in higher numbers now, more so than ever. In 2019 alone, there were 48 new novel medications approved by the FDA. That is the third largest number in the last 25 years. So now as providers, we're really running into the issue of not only how do we figure out how to utilize these in practice, but with new and novel medications coming out, usually those are going to be manufacturer owned as brand products for a period of time, and then potentially inquire a high cost for our patients. So it's kind of a double-edged sword here. We're learning a lot. We're advancing care for these patients, but also we do have to take in mind or keep in mind making sure we are able, the best medication for a patient is one they can pick up and they can afford. And unfortunately, all the data that we can see, if their patient can't access the medication successfully, we probably won't see those outcomes. So that's why we'll talk about some of the ways we can utilize medication access programs to help facilitate that. As I mentioned before, the best medication for a patient is the one that they will actually take. So this is a basic diagram of really all of the steps that occur from when the patient sees the physician or a nurse practitioner, whomever it may be, the provider in the clinic setting or via telemedicine, all the way to when they actually start taking the medication. Now, some of these are very self-explanatory, but some of these areas are problematic for us, where we may run into issues with insurance or cost of medication. So these two boxes that are outlined here on the slide are going to be the main kind of areas we're going to focus on today. Obviously, things can go wrong in the whole grand scheme of things. If, you know, with the creation of electronic prescriptions, we've had less issue with interpreting prescriptions and things along those lines. So these are really going to be our two primary kind of discussion points for today's discussion. So authorization of a medication is often going to be the most challenging, especially for these high cost medications, because if they're high cost, somebody's got to pay for it, whether that be the insurance or the patient. And so authorization is really dependent on a lot of different factors. I almost think of it as a decision tree. So first and foremost, the most important question to look at or ask the patient is, do they have medication insurance? Most important way to phrase that is by adding medication insurance, because for our Medicare population, obviously there are 3 different types of insurance, and prescription coverage is its own unique entity. So once we found out whether or not they have insurance, if they do, the type of insurance may influence what their formulary looks like, how easily they may be able to access these medications. And then the one other thing that's a little bit more difficult to kind of describe and to kind of understand is the time of year. You know, how should the time of year impact whether or not a patient should pick up their medications? And I don't mean, is it snowing outside and they can't physically get there? I mean, for specifically the Medicare population of patients, their copays will fluctuate throughout the year. And I don't quite know all the ins and outs of how that occurs and why that occurs and how to circumvent that in terms of applying for a Medicare Part D plan. But I do know, as a pharmacist and seeing it on the other side, what happens is there is a lump sum of money that Medicare agrees to pay for your medications. And once you've met that threshold, you essentially have to inquire more costs. So for example, if Medicare says I'll pay up to $500 of medication copays, once you hit that $500, they say, okay, now the patient has to pay 20% of that or something along those lines, where they're paying about $100. Once they've paid that, the patient themselves has made up that difference, then they'll start paying and covering the medications to a higher extent. How they get away with that, I don't know. I'm just telling you the facts, and that's what we run into. So these are at the bottom there. It talks a little bit about the differences between some of the medication plans and, again, some of the issues that we may run into and kind of things that may, some terminology to help us dig through really how to triage these problems. And again, the biggest takeaway I can say here, especially for the Medicare population, is just making sure that they do have a Part D plan, because some patients and some providers struggle with the idea they have Medicare, but they don't always have a Part D plan. This could be highly seen in your populations who have been relatively healthy all of their life and haven't been on a lot of medications, so they just chose not to inquire the extra $10 to $20 cost a month to pay for that Part D plan, or maybe they just inadvertently missed it. But that is one difference for the Medicare folks. Medicaid and commercial insurances are pretty similar. They have a strict formulary of what they would prefer, not strict, but they have a set formulary of what they would prefer patients to be on. And we do have some ways to triage if your medications that you're prescribing do not kind of line up with those in particular. So as I mentioned, since authorization is usually the largest issue, we do have some kind of, I call them Band-Aid free trial cards that we can utilize. We'll talk about on the next slide some cardiovascular medications that do have them. Again, I'm not trying to endorse any product here. I'm just mainly stating the facts of what's available. The primary goal of what these medication access cards are utilized for is exactly what I said. It's a bridge to assistance or to approval. So if your pharmacy, you've sent the claim over to the pharmacy sends the claim to the insurance, and they have said, you know, we deny this medication or it requires a prior authorization, it gives you time to combat that from your office or your location. These 30-day free trials do not bill the insurance at all. Insurance does not see that this medication is ever dispensed, and that's how we get around that kind of roadblock that we have hit. All patients are eligible for these. Unfortunately, they're usually only a one per lifetime use. So this is really something that can only be utilized when patients are first being discharged or first being initiated on in the clinic, and then we have to come up with a backup plan. I have seen many times where, especially in the transitions of care from the inpatient setting to the outpatient setting, folks get started on one of these medications, given a free 30-day trial card, and the follow-up of whether the approval occurs and the cost, assessing the cost for the patient, that gets a little bit lost. So this is an area that I do see the benefit of these cards. They're great to give us time, but especially from the inpatient to outpatient setting where you have multiple providers involved, it gets a little bit tricky. So my advice is always to make sure if you see patients on these medications that there is a plan in place that hopefully the patient knows, or the patient can tell you if they're too high price or if they're even able to receive the medication. Always something good to ask about. I will mention that with the pandemic ongoing, some of the pharmaceutical companies have expanded and allowed for 2 utilizations of free 30-day trials. That's going to be medication specific. So please check out their website if you're interested in any particular agent. So we're going back again to now that we've given out the free 30-day trial card, some of these can be buying time, as I mentioned, for a prior authorization. They will notify you if that is required, and usually it's just a couple of questions that have to be answered to explain or defend why this is the best medication for the patient. Then you have, once all of those steps are complete, 3 outcomes that can occur. The best is the top one, where it is approved and affordable, and patients go home with that medication the next day, and your office doesn't have to do any follow-up, and hopefully the patient tolerates the medication well. And if that worked 100% of the time I wouldn't be here today. So unfortunately, we'll talk about those who are approved, and the estimated copay is, I'm saying $500, but something that's too expensive for the patient to pick up on a monthly basis, or maybe the insurance company has just flat out denied. How do we triage, and what are our next steps when those things occur? There's a lot of words on this slide, I apologize, but hopefully you guys can use it when if you refer to the slide set. There's a lot of terminology that insurance companies will utilize. They may state that the medication is a non-formulary medication. This can be a reason for a denial, or this could be a reason for a high cost medication. It could be a reason for both. If you receive this response from an insurance company, they will always guide you in the right path to choose. Every insurance will be slightly different, but what you would be looking for in this ballpark is something called a formulary exemption. And what that is it allows you to write a letter stating why this patient really requires this medication. If there is a clinically meaningful reason that this is going to be the best medication for them, you can usually provide that information via a note with the case number, the patient's name, their date of birth. And then I personally provide supporting resources if I can. It usually works very well. It's not a requirement, but it does tend to work well if there is some supporting literature to back that statement. The other thing here, you can use it for previous intolerances to other medications. You can also use and state that they are intolerant to other therapies. Same thing here for a non-preferred medication. So non-preferred is usually you'll see someone who the medication is approved, but it still costs them, $200 or something, higher than what you would expect. And that's because they really would like you to choose another medication that's preferred on their formulary list. Oftentimes you'll see medications delineated by tier. And what that really means is that, a tier 1 medication is going to be their most preferred agent. They're going to cover a larger majority of what that baseline medication cost would be. Tier 2 kind of lays in the middle, where they'll cover, a smaller percentage of the medication, but they usually will approve it. And then a tier 3, they also, again, will cover less of that cost, and oftentimes would probably try to get you to use a cheaper option before they even approve the medication. So either way, appeal letters, a short and sweet, statement about why they need to be on it. Sometimes also providing documentation from a note, previous clinic note is also beneficial to supporting that information. And that's kind of what I also just described here, the tier exceptions. So when they get approved, but they're very high cost, eventually patients may end up asking for some support there. And then again, we can just utilize kind of the appeal process to create an exemption for that. So again, we're going back to our table here of what's going on with the authorization process. So after this is kind of what I was just talking about. So the medication is authorized, but still remains costly. We've tried to do the appeal process. The appeal process didn't work, or it still doesn't bring the cost down enough for a patient. Or some insurances may not allow the appeal process. They may say that it is what it is. They'll let you know in their decision letter. But so our roadblock here is going to be the high copay. Now we've done everything we can, and we still have a high copay. So for commercially insured patients, they can utilize Copay Cards, especially for some of those newer medications. Brand medications are often going to be the ones where you will have success with these, or they will be available. They're usually available on the company's websites. Sometimes they do have people who can come by and deliver physical copies for you if that's better for your patients to actually walk out of clinic with them. They cannot be utilized with any government insurance, so Medicaid, Medicare, the Veterans Affairs System, or TRICARE. They are not able to be utilized there. It has to be a commercial private payer insurance. And what those copay cards do is they essentially knock off a certain amount of money each month to a standard of $0 or $10 or $5. And what a lot of people don't really look at, I don't know if I go, oh, I'll talk about them when I get to the next slide. Alternative access, these are a couple kind of resources that you can use online. Either you can use them, your patients can use them. I often refer a lot of patients who have what we would consider to be, generic medications that have been around a long time that still cost about $20 or $10, and on top of their 7 or 8 other meds, end up spending $100-some a month on medications. These are utilized to look for the cheapest options in their areas. And then Prescription Hope, we'll talk about more in detail. It's actually a servicing company that helps with patient assistance forms. And then there are patient assistance networks that are open periodically for different disease states. And we'll talk about how we access some of those. And then your last option is going to be the patient assistance program. None of these aren't really in a, step 1, step 2, step 3. It really depends on the patient's personal situation and their insurance type, and we'll talk a little bit more about that as we go through. So again, copay cards are used with just commercial insurance only. What sometimes gets lost in the fine print on these commercial copay cards is that they usually cover a finite amount of money in a 12-month time period. So for example, if one of these cards says they will cover up to $3,500 and you have a patient who their insurance company approved use of these medications, but they still charge $400. You use the commercial copay card because it's a private payer, and that knocks it down to $10. That means every month you are using $390 of that savings. So this is actually not going to last the patient the entire 12 months. It usually lasts them about 8 months, and then they end up having to front the copay for that. One way to circumvent that, usually somebody who has that high of a copay still, despite having commercial insurance, it's a tier issue. So they deem them to be a lower tier, a non-priority medication. So writing the tier exemption would be something that can help you in the future to decrease the amount, have the insurance company cover more. And so if they bump that down to $200 a month, and then they're knocking that down to 10, your card should last the entire 12 months. That's a pretty hard thing to figure out because patients don't really know about those things. The only person who really knows is actually the pharmacist that's at the pharmacy. But it is helpful. You can ask some of those questions when you do run into a patient who runs out of medication coverage from a copay card too early. It's usually probably 99% of the time going to be this that's occurring. The problem is you can't really catch that ahead of time. You have to, you really find out when you're, on your heels already. So in that instance, right now, we do have the nice ability to be able to utilize the copay card, the free 30-day kind of trial card, since there are 2 uses for a lot of these companies. Or what you could do is prevent or not have them use the free 30-day trial card up front and just, have it on reserve if something like this were to happen. So alternative access websites, I just wanted to click into these just for a minute or two. I'm not sure if anyone on here is familiar with them, but GoodRx is a nice program that allows patients to type in, maybe I won't be able to go into them. I could just type it in on my screen. It is a nice resource that allows folks to look at low-cost medications in their area. So this is going to be your primary workhorse for generic medications that are just expensive. I don't suggest that you guys get too far involved in these things because they do take up some time. But for example, if they were looking for a generic allopurinol, you can type in here. It tells you all about the medication. And it will talk to you a little bit about where it's located and what the estimated cost would be. So this is if you were kind of not using insurance. Again, your insurance may change, but for uninsured patients or patients who are underinsured and still say, my allopurinol with my insurance is still $10. Well, could we find it cheaper elsewhere at a different pharmacy? They do have some copay or coupon cards available that you can educate patients to print these out and take them into the pharmacy. They are for each specific pharmacy that they look on here. So just a resource that you guys could utilize. Since I have this out of the screen, what I'll do is try to go ahead and get to the Needy Meds. Needy Meds is very similar to GoodRx, with the exception that it also incorporates patient assistance programs. So if you wanted to just find out what is available for a specific medication, this is a really good one-stop shop source, and patients can utilize it as well. So I'm going to go with a more expensive medication here and do
I'm sorry to cut you off, but I think to show us your screen, like the website that you're going to have to stop sharing and then reshare the website screen. So we're only seeing your PowerPoint still. I just want to let you know.
Yeah, no, thank you. So now I have to reshare. I apologize, guys.
No, you're all good.
So this one is the Needy Med website, which is a little bit more all-encompassing. As I mentioned, I can go back to the other one. Can you guys see it now?
Yes, that's perfect.
Okay, so if you're looking for a more high-cost medication, it has right here, this tells you about the patient assistance programs. If you click this link, this tells you about any coupons or rebates that are available for that medication. Support pages will tell you there as well. So we'll dig a little bit deeper. We'll see who the pharmaceutical company who makes it. Their patient assistance applications and forms are all located here in both English and Spanish. It tells you about the eligibility requirements right on the front, which is nice. How to turn the application in, how the medication is supplied. So some of these companies will send them or attempt to send them to your office, but this one is nice that you can send it to the patient's home. And then if you continue down, you can actually see what patient assistance foundations are open. We'll talk about these in a little bit, what they are and what how they work. But it has all of this readily available with all of the inclusion exclusion. So this is really a nice resource if you're trying to learn a new medication or you're not as familiar with some of these to get all of those. The other one, I'll quickly show you GoodRx while I have it open. Outlet while I have this open. It's helpful, but it's not as all-encompassing, in my opinion. This just really, again, our example was a generic and allopurinol. It shows you local pharmacies and what their cost would be for, an uninsured patient just with this coupon. Okay, so now I'm going to go back. No more sharing, sorry. And the last one on there is the Walmart $4 list. So there are a lot of generic medications that can be found on there. So it's usually $4 for a 30-day supply or $10 for a 90-day supply. This is going to be most helpful for folks who, again, are non-insured or, potentially their insurance does not cover as much as what this benefit would be. If you switch pharmacies, you do get their bottom line chart. So Prescription Hope, I won't click on that link. You guys can look at it if you're interested. It's a service that coordinates patient assistance applications, because I think everyone's probably thinking on the line, patient assistance programs, this is so much paperwork, I don't have time. And initially I thought this was a really great program. The problem is they actually do charge a service fee to the patient, $50 a month. So if they're already not really affording their medications, I don't know how open most patients would be to utilizing this. Personally, I don't have any patients that have done it, but it is an option for patients who may be able to afford that. And then Patient Access Network or foundations. There's a few of these. This is just one example. Those all rely on donations, and they're disease state specific, and they rotate with where the funding goes. So if you're looking specific for cardiovascular medications and assistance with getting those for cheap or free, that rotates through, and there may be one time throughout the year, 1 or 2 times throughout the year that this is open for patients to enroll. So it's something that patients have to continually check back for. It's not a reliable source for patient access, but it is something that, that some of our patients have utilized, and once they get linked in, I do believe it's a pretty successful program for them. It's just a matter of if all the stars align for you and your patients. Again, for use by the uninsured or the underinsured. Same thing with the patient assistance program. All of them are going to be very different based on their the actual company themselves, but generally they have some income requirement that is around the federal poverty level. They all have to reside in the United States, and Medicare Part D patients who spend more than 2 to 4% of their prescriptions will also have to submit that information if they are applying. So this can be an option that is useful for your Medicare Part D patients. It will help you prevent and navigate the donut hole I described before, when patients get really high copays about midway through the year. But the downside is it does require some paperwork. These are just some reviews of pretty much everything we already went through for someone who does not have insurance, so I'll let people utilize this on their own. This is something that I recently learned about. There are some, I guess, extra help abilities from the government for those who do have a Medicare Part D plan but still struggle with the coverage of their medication. They can go to this website to look and see if they meet criteria. It is a very strict criteria in terms of the total, I think it's not even an income-based evaluation or assessment. It's actually your income plus all of your assets. So it looks into like a home and all of those things. So again, it's pretty difficult, I think, for patients to meet criteria, but could be something that, you know, if we are really struggling for options, we can give to them as a potential avenue, and they would fill the application out online.
Rachel, this is Joanna. I just want to say that we do have patient navigators in the population health that help patients. They'll do this verbally with the patients.
Oh, great.
So that's very helpful.
Have you guys had a lot of success, Donna?
They do have a lot, and they'll do, you know, they're referred mostly, those patients are mostly, I'm a disease management coordinator in population health. So most of those patients are referred to our patient navigators to do that process through, there's 28 of us case managers. So we refer a patient there. So most of them are referred to there, but definitely people outside can utilize those patient navigators. And they do, we have 3 pharmacists on our team. So a lot of times those referrals also come from pharmacists after they do a review with the patient's medication. But they do, they can get full help, partial help, or no help. So and it's a percentage. So, you know, like you said, every little bit helps when these folks are tight with what income they have, so.
Yeah. Thank you for sharing that experience. That's really great. Honestly, I don't know if our group has utilized this as often as maybe we should have, but when I was digging through some information to put this presentation together, I actually learned a lot about it. So we may, you know, reach out for some further information, but I really appreciate sharing your experience. And then the last thing that I did is I just kind of put together some information for our cardiovascular medications specifically. So it's not an all-encompassing list. It was just some things that I thought of quickly off the top of my head, and maybe try to guide you guys to what the most likely resources or what resources there are available for each of those in particular. And so, you know, the first chart here has mostly generic medications that have been around for a while, used for hypertension and heart failure. Not a lot of copay card or patient assistance help from these because, again, they are a generic medication at this time. But you can utilize these resources. I mentioned the GoodRx website to look for local, as well as it does include which ones are listed on the Walmart $4 list. So this may be helpful in the future if you guys, if anyone struggles with any of these medications. Again, we continued on to some of the other more specific, I guess, heart failure medications. As you can see, the top 3 there are going to be kind of the previous They've been around for a while. They're mostly generic medications. Coreg CR, which is a extended release formulation, does still have a patient assistance program. I believe that is still manufacturer run at this point in time. We don't utilize a lot of that medication, but I believe it is available. And then down at the bottom, about halfway through, we start seeing some of the more recent medications that have come to formulary or been approved by the FDA in the last 5 years or so. This is just a pretty basic outline of what things are available, whether they have free trials, whether they do have a copay. Again, we talked about who fits into all of those categories and what's appropriate for them. And then there are links to the patient assistance programs if anyone is interested in filling those out. Some of them are medication specific, others are just going to be manufacturer specific, and you select the medication that you are applying for. And this is actually, I believe, the last slide I have on here. It is anticoagulants and antiplatelets. There are a lot of these that have come out in the last, I guess it's been a little longer than 5 years, but some of these anyway. And again, all of them, these costs are estimated at $500, but I don't know what they actually are as a cash paying customer, but they are high cost, I know that. And so most of them do have the free trial and the copay card, and the patient assistance programs are available for use with, you know, the provided the supplementary paperwork and information for that. For patients who are filling out patient assistant forms, our general process here in our clinic is usually kind of owned by our social worker, just because if one person owns it, that's the best way for it to happen. But we often identify them as pharmacists when we see them in clinic, and so we'll communicate with her. We will fill out, usually with each one of these, there is probably one paper that needs to be filled out by the physician and the physician group, and that is essentially the prescription with the patient's name on it, the quantity, how they're going to take it. We take care of that in our clinic, or the social worker takes care of that in our clinic, and then she will also take care of sending or providing the patient their form. Their form usually is about 2 pages where they're signing an agreement to allow the manufacturer or the company to utilize their health information. And then it also provides their, some of their demographic information and their insurance coverage. So all of those, we essentially give those or provide those to the patient either via, like I said, handouts in clinic, or we send them via mail, and then it becomes the patient's responsibility. And that is kind of one of the hard parts of patient assistance, and that's where that Prescription Hope program has found their niche, is being able to reach out to those folks and keep them engaged in the process. Most patients are interested in learning and trying to find ways to cut their costs. So I would say for 10 applications we send out, we pretty reasonably get 85% of those back without having to do too much work on the back end. The other thing that patients will also have to provide, so as an education point for them when they are given this information, is usually a W-2 form, a Social Security statement, or you know, some kind of proof of income from the last year, so that they, again, we're going to talk about how they meet certain income requirements. That's really how they show proof there. There's also an place to estimate it on the application, but they usually would like something in kind of concrete as well. What questions do you guys have that I can help with? Medication specific or our process or anything?
Thank you so much, Rachel. That was awesome. Super comprehensive. And I will be including your PowerPoint didactic in the recap email for everyone to have a copy of, so they can go to those websites and everything. Donna, was there a question you had?
Well, I just wanted to say that when I do those patient navigators, of course, when I was in the office, now I'm not there, but they sit right in the same room as me. I have, and those are sensitive questions, like you said, Rachel, they are about like what assets you have. And it does take the interview, like you said, they're kind of a lengthy, I'm thinking maybe 20 minutes, and the patient navigators tell the patient that up front. And then they do tell the patient, I believe it's about a month before they'll hear an answer on that. So just so you know, it's not like immediate. answer. And we definitely, I've taken training. My pharmacists have showed me the needy meds, and I actually took a training on there on how to use it. We use that one a lot. And if people do belong to Sam's Club, because of course that's a cost to belong to Sam's Club, but they have a big list of reduced medications too. So if they are a member of Sam's Club, that might be another place. And I have had some patients that do belong there, and they've been able to get like some of their medications cheaper without using their insurance. They can get it, cheaper there. So just heads up as what I found. So thank you. That was very informative.
Yeah, thank you, Donna. And, for everyone on the call and for me as well, could you expand a little bit? I know population health is available, but do you guys take out external referrals, or is that a local thing, or how does that actually work if they're interested in, reaching out to some of those?
We work with the value-based patients. So they have to be ACO, ASO. We have the health plan patients.
Okay.
So they have to have the gold banner when you go into Epic. If they have a gold banner, then that is a patient that we could work with. We do have DMCs, we're called disease management coordinators, within a lot of clinics. So all the Morgantown, but throughout the clinics in West Virginia. And I actually will be stationed eventually in the Waynesburg clinic in Pennsylvania, because I live in Pennsylvania. But we have an office. Our main office is over at the Rock too. So we're right there. But we can, if you have a gold banner patient that you're interested in seeing, usually like our DMCs that are embedded in the clinic, they work directly with those physicians and can, get a referral from the physicians. But I have lots of lists that I look at for patients. I got a 955 patient list from the health plan. So, and I review new CHF, new COPD, and new diabetic lists once a week to see if there's a potential patient there. But those are filtered for me to be value-based patients.
Sure.
Okay. But I think like the nurse navigators that are 24 hours, 7 days a week, nurse call line, that is for any patient that uses WV medicine. So I think our patient navigators they also help arrange transportation for patients. If possible, Uber's been down, right now with COVID, there's less rides, but they work with the circulation there. So we have a lot of resources within that department. So feel free to reach out, because I certainly don't know about all the things that we do, but just my small part. But if you have a patient that has a need, we certainly can look to see if there's anything we can do to help.
Yeah, and your experience is very, helpful to hear about. So I appreciate you letting everybody know. Anyone else have any questions or comments or anything I can help with? Medication specific things. Like I said, I tried to keep this pretty generic so that I wasn't pushing anyone towards one way or the other, but I do know in the cardiology world, especially, things are just coming out left and right. And, we struggle with the same things that you guys do in terms of patient cost and patient access. And that's the biggest thing, is really patients are going to benefit the most from what they can take and what they can reliably take. And we don't also want to force patients not to be having, a good breakfast, lunch, and dinner just to take, medication. So.
Well, I'm not a clinician, so I don't have any specific questions for you, but I have a lot of questions regarding the didactic. But no, that was awesome. And thank you, Donna, for sharing all of that as well with the group. Any questions? Shane, I know you're with LMU and over in Cali, but were there any questions you had as well?
No, I think it was very well presented. Yeah. We don't have Sam's Club out here. We have Costco, but Costco does kind of the same thing. It's pretty discounted, and they get a lot of times they get cheaper meds through Costco than they do even Good RX. So.
Oh, good to know.
Thank you. Any other comments or thoughts, questions for Rachel? I hate to keep you all longer than we have to, and as always, just feel free to email me if you do have any questions after the fact. We do have a little poll that we are conducting just to get some feedback from you all. And it's really brief, I promise, just 8 questions. So I might launch that if we end here a little bit early, but just a couple housekeeping announcements. The next session will be on October 16th, and Chris Bianco will be presenting on transplants. So keep an eye out for that reminder. I'll be sending that out about a week before. Thank you so much, Rachel. That was awesome. Again, I'll attach your PowerPoint to the recap email so everyone has access to all those great resources. But let me go ahead and share my poll for my screen for the poll. Let's see. Are you all able to see that okay? And then anytime you guys finish the poll, just feel free to hop off here. Thank you.
Yeah, thanks again, guys, for having me and logging in. Talk about expensive medications. Transplant is a doozy, but I didn't go into that one. I'm not sure Dr. Bianco will either. Enjoy your weekend. Enjoy the nice fall weather. Hopefully you guys all have, as we do up here in Morgantown.
Thank you so much, Rachel. We'll see you next time.